Excellent. Welcome back, everybody. I thought I'd start by saying hello. My name's Angela Colink. I'm from Family and Community Services here in New South Wales. And with me today I have two colleagues. I was waiting for at least one of them to return back before I was able to start that introduction. So I have a colleague here, Matt Fries, and our director, Jackie Astolfi, isn't too far away. So the three of us will be available to answer questions at the end of this presentation and also during the break. So I guess one of the burning questions you now have, hopefully, is what does all of the previous presentation mean for you as practitioners in New South Wales when it comes to authorisation of restrictive practices? Well, hopefully this presentation will help to answer some of those questions for you. Many of you, as practitioners operating in New South Wales, should be reasonably familiar with what restrictive practices are. So you may notice from the first part of this particular slide that the definition that New South Wales is going to be using in relation to restrictive practices is now just a little bit different. So for New South Wales, restrictive practices involve the use of interventions and practices that have the effect of restricting the rights or freedoms of movement of a person with a disability. And this includes the 5 categories that were previously mentioned. What you might notice with that particular definition is that we're not using the term restricted practices any longer. So the reason we had that previously was that within our policy context, we had identified a range of practices that were so restrictive in nature that their use was restricted and therefore required authorisation. That distinction now sits in the Commonwealth space, and that those practices have been identified as regulated restrictive practices, which allows us to adopt the restrictive terminology, which I think might make things a lot simpler for many of us. If you haven't had that confusion yourself in terms of what's the difference between restricted and restrictive, you may have had conversations with colleagues about what's the difference and potentially service providers trying to navigate that as well. So we've eliminated that particular confusion by adopting the term restrictive practices. The next point is a point of clarification. So this isn't new, but I think it was a point that was often misunderstood when it comes to what does authorisation mean. In many instances, I think providers thought that it was the practice itself that was authorised, and I think some of the questions earlier certainly alluded to that perception, in that if a practice was authorised, it could be used across contexts. That would only be the case where the content of that authorisation decision had actually given consideration to the implementation of that practice across those settings. So where the decision to authorise was made based on one setting only, it wasn't a transferable practice. So, to be clear with that, restrictive practice authorisation is the endorsement for a particular practice to be implemented by staff with a certain individual in a particular service setting under clearly defined circumstances. So you can see that by authorisation being about the implementation within a particular context, it's not a readily transferable practice. Authorisation needs to be specific to the context in which it's going to be implemented. And certainly the decision to authorise must consider the use of the practice within the context of a behaviour support plan, which was based on a functional assessment of behaviour. And that's not a new requirement either. So from July 1, we've heard a fair description around what the Commission will require when it comes to behaviour support. And behaviour support guidance will come from the Commission itself. But within that, there's the expectation that authorisation for practices still occurs according to state expectations or state requirements. So what are New South Wales state requirements going to be in relation to restrictive practices? We will still expect service providers to comply with the New South Wales Restrictive Practice Authorisation Policy. So you may not have heard that title just yet. We will replace our behaviour support policy with a restrictive practice authorisation policy. The reason for that is that behaviour support itself, as I mentioned, the guidance will come from the Commission in relation to what that looks like and how that service is to be delivered. That means for New South Wales, we need to be really clear about what are our authorisation requirements. And we're outlining those in the RPA policy. That will be accompanied by a New South Wales Restricted Practice Authorisation Procedure Guide, which will outline how to implement the requirements of that particular policy. So for New South Wales, the means by which authorisation is provided will continue to be the authorisation panels that are currently being operated by service providers in New South Wales. If you don't have a restricted practice authorisation panel, you may be accessing a panel of an associated service or within a consortium model type of approach. That is still going to be the required means to get authorisation, at least for now. And I say for now because one of the things you may remember from Paul's presentation was that one of the last additions to the legislation in relation to the creation of the Commission was the need for a conversation to develop nationally consistent approach and minimum standards regarding authorisation. What that may mean, and what that's likely to mean for New South Wales, is that some of the requirements and minimum standards may shift a little bit. So this is a model that we need to have in place that will get us through to what the next model might look like. So while service providers have been expected to have their own panels, that will continue for the meantime. What I can't say is whether that will or won't be the requirement down the track, but certainly it's the model that we need to have in place for now. With that, there's an acknowledgement that for service providers, it's quite a resource impost to operate your own restrictive practice authorisation panel. And I think one of the most frequent questions that I get asked since the NDIS and the NDIS has been announced and we've been working towards its full implementation is that authorisation panels aren't funded via the NDIA. So how does that get appropriately funded or supported for services? The short answer to that is that it will still remain a cost of doing business. However, we acknowledge the impost that has and that we've taken a number of steps to try and decrease the resource implications for operating a panel. One of those is the development of a New South Wales-based online platform to lodge submissions. That platform is intended to be, and I'm being repeatedly reassured, will be functionally operational next week. It will allow for the uploading of submissions as well as the generation of outcome summaries that will help to record what decision was made within an RPA panel. That online system will replace the paper-based, heavily administratively burdened type process that has been the case so far. So it will have decreased resource requirements for that particular purpose. It will be a secure system to manage your own applications. It will also be a means by which you can track what applications or submissions and approved practices are in place for your service. It will have a reporting function that won't be operational initially, but within a short period of time will allow for the generation of reports that you can then get a sense of within your own service how many of these particular practices or how many practices does this particular person have, how soon or how many practices will expire over the next period of time. It will also include alerts and notifications to the person who's the administrator of the system to be able to flag when those expirations are coming up and what actions are required. So while not all of those functions are going to be operational by next week, it will still be a process by which submissions can be lodged and outcome summaries can be generated. So one of the areas that you might be interested in is what's changing and what's staying the same for New South Wales. As I mentioned, panels are staying the same in that there's still the expectation that panels will be expected to be operating within services. Certainly restrictive practices should be minimised and, where possible, eliminated. That's not changing. All restrictive practices should be used in the context of a behaviour support plan, which is based on a functional assessment of behaviour. That's not changing. New South Wales government policy requires authorisations to be in place for the use of practices. That's not changing either. Consent for the use of restrictive practices is also needed. So the consent requirements aren't changing. We will certainly be having a conversation with the Guardianship Tribunal in the coming weeks to make sure that they're familiar with what our change in definitions are and what our requirements associated with consent is, and particularly in the context of restrictive practices. Now, a question that came up recently in relation to the issue of consent when it comes to restrictive practices is that from time to time, when the Guardianship Tribunal has been approached in relation to getting consent, that what they will or won't decide on isn't necessarily consistent with policy expectations. Certainly, our consent requirements haven't changed, and as I mentioned, we'll be having a conversation with the Guardianship Tribunal in the coming weeks. We've used a lot of the feedback in relation to the issues that have arisen when it comes to what the Guardianship Tribunal would or wouldn't provide consent to in our feedback to the New South Wales Law Reform Commission as part of the review of the Guardianship Act. So certainly the issues that service providers and clinicians have experienced when it comes to gaining consent, we've taken those on board and we're making sure that they're reflected in our feedback to the New South Wales Law Reform Commission. And certainly one of the main points from this morning is that the unauthorised use of restrictive practices remains a reportable incident. So what is changing? The Quality and Safeguards Commission has provided a definition of restrictive practices and we're adopting that. So it's restrictive instead of restricted, as I mentioned. We're also aligning with the 5 categories of restrictive practices that were described earlier. And hopefully that will decrease the potential confusion between what's required in New South Wales versus what's required at the Commonwealth level. We were certainly in a potential situation that according to the Commonwealth definitions, all of those practices would still require regular reporting. So what we didn't want to have in place was a system by which service providers needed to report against one set of definitions, but still have authorisation expectations in relation to a slightly different set of definitions. That means for New South Wales, the biggest area of potential impact is the issue of routine dose medication for the purpose of behaviour support. It's the area in which we're likely to experience the most individuals that don't have behaviour support plans that provide the appropriate context for the use of that medication. And certainly the transitional requirements associated with engaging with the restrictive practice authorisation system, we've aligned those with the Commonwealth as well in terms of the timeframes to get interim support plans in place and authorisation, etc. So where there's ambiguity in the overlap between behaviour and mental health treatment, it will lead to some teething problems in relation to a reasonable decision-making framework regarding that particular issue. New South Wales will continue to work with the Commonwealth on attempting to clarify that issue. If you have any questions about any particular situation and are unsure where it fits in relation to the application of medication, whether it fits with a mental health diagnosis or in relation to behaviour support, and you're looking for a sounding board or advice as to how to consider it, by all means contact us. I'll provide information about how to do that later, but by all means contact us. And if you don't have or the Commission, and if you don't have, if it's a question that stumps us, we'll certainly be in contact with the Commission to make sure that we provide a response that's consistent and mutually agreed upon. It will also help to inform future resources that either we or the Commission develop. Oh, not yet. All right. So the other element that's changing from July 1 is the national oversight of behaviour support, and that sits with the Commission. It was described earlier. So it no longer sits within the New South Wales policy context. All your behaviour support guidance will come from the Commission. So our behaviour support policy and its associated practice guide are out of date and non-effective from June 30 until the Commission provides resources specific to the area of behaviour support. The behaviour support practice guide material still aligns with the elements of best practice that are reflected within the competency framework that as practitioners you'll be measured against over time. So until the Commission provides resources, that practice guide still provides reasonable advice. NDIS providers can administer and manage requests through for authorisation through the online system. So that's something that's going to be new for many providers. Where the system will ask for data in relation to the use of restrictive practices, it is for the purpose of the decision-making process around authorisation. For many of you involved with either submitting a request for authorisation or considering whether or not to provide authorisation as a panel member, would have come across situations in which you need data on which to base that decision. You can't make a decision to authorise or not in the absence of reasonable information about the potential frequency of use or frequency of actual use. So in this context, it's simply about informing the decision to authorise. And for those of you in the audience who had eagle eyes, you may have noticed that when Tracy was talking to some of the screenshots of the behaviour support screens that you will experience when you upload your support plans, there was a little export button under the reporting function for providers when it came to reporting the frequency of use of practices. That export button will allow you to export and download a summary of that data, which would be quite acceptable to include in the submission for authorisation with the state system. All right, so for New South Wales, aligning with the Commonwealth definitions, our definitions that we have used align reasonably well with the 5 definitions. So seclusion and exclusionary timeout will both come under the category of seclusion. Physical restraint will be teased out into the 2 areas of mechanical restraint and physical restraint. Chemical restraint will absorb our PRN medication quite logically, and there's an asterisk there for routine dose medication for behaviour because we haven't previously considered that a restrictive practice. And as I mentioned, that's likely to be one of the biggest areas of impact for our change of definitions. And similarly, restricted access and response cost will both align under the definition of environmental restraint. Now, these slides will be provided to everybody who provided an email address as part of your registration for today, and the presentation will also be available on one of our websites, if not both of our websites, in the very near future. So in relation to the transitionary arrangements and timing for aligning or engaging with the New South Wales RPA system, these timeframes are consistent with the Commonwealth definitions. Just had to double check on one of them that we made an amendment to from last week. Yes, so in relation to practices that already exist, there's consideration as to when authorisation was given, whether it was pre-July 1 or whether it's anticipated to be post-July 1, and whether it exists within a behaviour support plan or not, and what the requirements of the transitional arrangements are. Now, those timeframes are the timeframes that you will see if you've picked up and read the NDIS rules regarding restrictive practices and behaviour support, and will also be reflected in our behaviour support behaviour support policy, not behaviour support policy, restrictive practice authorisation policy. So I think from from some of the questions earlier, I got a bit of a gist that one of the areas of interest is likely to be interim authorisation, and what does that mean through the transitional process. Certainly we have interim authorisation listed over to the side, but in relation to what does that mean for timeframes or expectations associated with interim authorisation, it's worth keeping in mind the crisis response context in some instances, and I know that was part of a question earlier, where a restrictive practice is required in the context of an incident that wasn't expected, it was a new behaviour. There is still the caveat that you can use a restrictive practice in that context with the acknowledgement that it's an unauthorised use of a restrictive practice and requires a reportable incident flagged with the Commission Critical Incidents Division, Critical Incidents and Complaints. Until that strategy is contained within an interim behaviour support plan, if not a full behaviour support plan, and obtains interim authorisation, it stays as a reportable situation. Part of the purpose of that is for the mapping of the duration it takes for behaviour support to become involved. That will help highlight for the Commission market gaps and readiness of the sector to be able to respond effectively to behaviour support demand. So this system, the authorisation system, wouldn't expect services to engage with it until there's the need and the appropriate documentation to get the interim authorisation that goes with the strategy that contains the practice. Does that make sense? Yep, okay. Okay, so interim authorisation. In exceptional circumstances, interim authorisation for the use of a restrictive practice is required pending the development of a full behaviour support plan and authorisation by an RPA panel. The interim authorisation should be sought as soon as practicable and not exceeding 3 months. So within the 3 months that was outlined on the previous slide, you need to obtain interim authorisation. So within that 3 months, an interim behaviour support plan needs to be developed as a minimum that wraps strategies around the use of that particular practice, and authorisation needs to be obtained promptly. That interim authorisation can be provided by a senior officer of the provider, and that senior officer would have regard to both the interim plan, or if it was able to be contained within a full behaviour support plan, yay, but they'd give consideration to the behaviour support documentation. And they would also have regard into the context of their operational expectations and the implementation of it as a provider. In providing interim authorisation, the senior officer or the senior manager of the provider specifies the length of time for which interim authorisation is valid for, and there's a bit of a caveat on that. That 5 months should be 6 months, but it's within a 6-month period of time. That allows for the development of the full behaviour support plan that would go with that particular strategy. So essentially, each provider should have someone identified who has the delegation to be able to authorise in an interim capacity the use of a practice where the need for that authorisation is such that you can't wait for a full panel to be convened. I've been using the language senior manager, senior officer as opposed to senior manager as an acknowledgement that in many services there will be senior clinical or behaviour support personnel that would be appropriate to provide that decision. For services that don't have that senior behaviour support person, it would be appropriate for it to be a senior manager. And preferably the senior manager that chairs the restricted practice authorisation panel, because they would have content knowledge and understanding of what the process and expectations are of that authorisation mechanism. And full authorisation can be provided for up to 12 months. That's the same as it was, and the RPA panel must not specify a period longer than that 12 months. The reason for that is that consent can only be provided for a 12-month period, so authorisation can't exceed the duration of consent. All right. Don't fear. It looks a bit complicated. Essentially, that's a little bit of a map that sort of describes the process of behaviour support and authorisation. So most of you should be reasonably familiar with the process by which behaviour support occurs, the identification of the use of a restrictive practice, and the engagement with an authorisation system. Essentially, that's what that represents. That will be in the package. I'm pausing because I know that that's going to be replaced by some screenshots of our online system within the next couple of days. So what I was about to say was that that slide would be in your hand in the presentation when it's sent to you. But the pause was, I wonder if it's sent before or after the screenshots get added. So if it's sent after the screenshots get added, don't worry about that slide, because essentially, as I mentioned, it's the process by which most of you already operate when it comes to being engaged as a result of an incident of behaviour happening, where the use of a practice has been flagged. You develop either an interim plan or a full behaviour support plan, seek authorisation for that, get authorisation and consent appropriate for the use of that practice, and then make sure it's implemented. What that identifies is a couple of points at which engagement with the Commonwealth system also occurs. One of the features of our New South Wales online system, and I think I mentioned it before, is that an outcome summary will be generated as a result of the decision made by the panel. That will include the key elements of information that you probably already have within your outcome summaries, the type of practice, the duration of authorisation, the people that were on the panel that were party to that decision, as well as any additional recommendations or requirements that the panel may have for the use of that practice, the monitoring of that practice, and whether or not they expect it to come back for a review. So the system will allow for the mostly prompt generation of that particular document. Some of it will be auto-populated from information that came from the submission itself, so it will be less of an arduous process than generating the outcome summaries you may already experience. The next slide is in relation to interim authorisation regarding practices. And again, it represents largely the same process that you've already undertaken when it comes to behaviour support. The only key differences will be where the system will engage with the Commonwealth system when it comes to reporting, or when it comes to making sure that documentation regarding authorisation is part of the support plan. So as you develop your behaviour support plans in the Commonwealth system, it will ask for a prompt for a response in relation to whether or not the practices contained within that plan are authorised or not. The authorisation of those practices is the responsibility of the implementing provider. So you yourselves will not need to seek authorisation. It's the implementing providers that do the authorisation and lodge the submissions through their own mechanism. Where you connect with that is in the provision of the draft behaviour support plan that sits in the Commonwealth system, which can be exported and uploaded into the state system. The state system, in relation to the outcome summary, will be downloadable or exportable and uploaded into the Commonwealth system. So they're the main connection points between what the Commonwealth will require in relation to behaviour support plans and authorisation requirements, and what our authorisation process will require when it comes to documentation and how we connect back to the Commonwealth system. So in relation to interim authorisation, rather than going to the full panel, it will still be that designated officer within your service or within the service provider that identifies that authorisation has been given and considers the decision to make an interim authorisation decision. That will still need to be entered into the system in order to generate an outcome summary with the same type of information in terms of the duration and any additional requirements of the clinical work. One of the features we're building into it, and I'm not sure if this is going to be available in version 1.0 0 or 1.1 will be a notification back to the practitioner in relation to the outcome summary. As practitioners, you're going to want to know what decision was made, and if there are additional recommendations that impact your clinical work, what were they, and what will that then mean for how you go about continuing to provide support. Okay, so the authorisation panel remains the mechanism for authorising the use of restrictive practices. The panel includes at least 2 people. Now, this is a slight difference to what you may be familiar with when it comes to authorisation panels previously. With what we have outlined previously, the roles or the functions of those people are still represented with these 2. So the role of a manager within a service to be able to provide operational endorsement that yes, the service is aware of and supports the use of the practice and has made sure that their staff have had the right training and support in the implementation of that practice is still needed. So you still need to have a manager, or the service provider will still need to have a manager on that panel. That panel will also need to be informed by behaviour support, knowledge, skills and experience, particularly in relation to restrictive practices, and to have independent consideration of the use of that practice within that service. Now, the function of that independent person is to make sure that a conflict of interest decision isn't being made by representatives of the service and putting the need of the service above the need of the individual. What this is an acknowledgement of is that where you have a behaviour support, where you have a person on the panel with that behaviour support knowledge and experience, if they're external to the implementing provider, they can also bring that external and independent perspective to the panel consideration. So you can get away with 2 people on the panel as opposed to 3. Panels can still include additional members as required and appropriate by that particular implementing provider and how they operate their particular service. It could be that they want to include someone with speech pathology skills and experience specific to strategies that might overlap with behaviour support. Or they may want to include someone from a justice-based background in relation to consideration for practices for individuals with some fairly complex support needs that have intersections with the justice system. So the panel will receive the submissions from the online-based process, and all panel members will be given access to the submissions that sit within the system. So there's less of a need on services to collate, to coordinate, to distribute, to make sure that all of the relevant documentation has been provided by the people that are lodging the submission, because there will be mandatory fields associated with those minimum requirements. If those minimum requirements aren't met, the submission can't be lodged. Certainly panel members cannot make a submission to that panel. I think that's reasonably well understood, I think, in that panel members can't lodge, or a panel member can't consider a submission that they've been party to the submission of. It's a clear conflict of interest. But certainly having expertise in relation to behaviour support on that panel is absolutely essential. Similarly, in relation to conflicts of interest, where we've identified that a panel member may serve more than one function in relation to management, behaviour support, skills, knowledge and experience and independent expertise, clearly the manager can't be the one with behaviour support, skills, knowledge and expertise, because there's too much of a potential for conflict of interest decision to be made, even inadvertently, in that it will be hard for anyone in a position to either decide between their manager side of the brain and the clinician side of their brain in terms of identifying what's the best decision for the person in that instance. So where there's a duality of role, it's in the clinician and the independent function. All of those functions, those 3 functions, will be identified on the outcome summary. So where you have somebody who serves 2 functions within a panel, they will be required to sign off against each of them to say, yes, I've given this consideration in the context of behaviour support knowledge and understanding, and yes, I've given consideration to this in the context of being an independent person from service delivery. One of the additional ways in which we're acknowledging the impact of this requirement on service providers is that it may be difficult to source and resource having a behaviour support clinician that might be external to a service on the panel. So one of the questions under the market that we're headed to as of next week is, how does any service fund or afford an independent behaviour support specialist on their panel? If they don't already have access to one and have an arrangement with one, FACS are in a position to provide an independent behaviour support specialist for the purpose of attending the panel and giving consideration to submissions. That will be on request. It's not a requirement that you use a FACS person on authorisation panel, but we will be putting together a collection of behaviour support specialists specifically for the purpose of being able to attend panels on request. The means by which service providers can request an independent specialist from our register of specialists will be by email at this particular point in time, but there will be a function within the system for services to request that support. So what will our ICT system include? Essentially, the purpose is to manage and authorise submissions of restrictive practices. Services submit the request that will include the behaviour support plan. Practices shouldn't be considered to be authorised in any way, shape or form if they are not supported by behaviour support documentation. So interim behaviour support plans will be accepted in situations in which there has not yet been the time to be able to undertake a behaviour support assessment and to get a fuller plan in place. The resource the platform will include, perhaps not initially, but certainly quite soon, it will include a self-assessment tool to determine whether or not authorisation is required for that particular practice. Those that will have access to the system are NDIS registered service providers, behaviour support practitioners, and those that are identified as core panel members. There will be access to the system via that web address towards the bottom of the screen. Submissions are lodged to the panels via that process for consideration. And the system will record decisions as a result of those panel considerations in the context of an outcome summary. Now, one of the requirements of this New South Wales-based system is that service providers essentially report on the authorisation decisions from panels. By engaging with this system and the generation of outcome summaries, that reporting function will automatically be fulfilled. So essentially it's not adding a reporting requirement. By engaging with the system and using the system to generate the outcome summaries, there's no additional requirement of reporting. It's inherent. Service providers will be notified of the outcome of expiration of authorisation. So where panels have flagged a review of a practice sometime within the duration of authorisation, as well as the expiration of authorisation, they'll get a flag to say this practice is due for review within X number of days or weeks. So on the left, we can see some of the requirements of the Quality and Safeguards Commission and what that then means for the New South Wales platform. Most of those things have been captured by discussion so far. So as a result of the expectation that all regulated restrictive practices are authorised according to state requirements, our state requirements are that authorisation needs to be obtained, and that is obtained via engaging with the online system, lodging submissions through that, having that submission supported by a behaviour support plan, is considered by the panel, which considers review and evaluation of the proposed practice, ensures consent's obtained. An outcome summary won't be finalised until it's clear that consent has been obtained, and decides whether to authorise the restrictive practice or not, and records that decision in the outcome summary. That outcome summary records the findings of the panel, records consent, panel member approvals. Now, we're building a feature into the system that if you are ever a person who sits on an authorisation panel to provide that expertise, in being party to that decision, as the service provider generates the outcome summary, that has to come back to you to make sure that what's contained in that outcome summary is as you remember that discussion having been the content of that discussion as it was undertaken and the decision that was made, so that you can say, yes, that is as I remember the decision to be, and allows the potential for that shift or drift in relation to what was decided versus what was documented. And that outcome summary can be uploaded to the Commonwealth system to provide evidence of authorisation in order to assist in the finalisation of your behaviour support plans. Now, this next slide provides a bit of an overview of some of the core functions or core functionalities of the system. And essentially, there are a whole heap of benefits. As end users, and we've got those over here on the side, practitioners, service providers, independent panel members and FACS administrators, by using that platform, there are a whole range of benefits. So you may have already been able to pick up some of them from the discussion so far, but certainly the centralised lodgement of applications is one of them. Mandatory fields to ensure that minimum information on which to base a decision is provided before the submission will be accepted, rather than the person collating and chasing up information if it's not in the first attempt at submission. Management of panel member allocation and panel member access to submissions. So one of the elements of functionality of the system is that as a provider, they'll be able to identify who were their panel members, and they will automatically get access then to the collection of submissions for any particular panel date. It will include the function to request assistance with panel membership, and that's where requesting someone from the FACS Independent Behaviour Specialist register will come into play. Provides reminders and notifications, which I've mentioned a few times. Reporting of decisions to authorise is automatic, with completion of the outcome summaries. It provides the service with the tracking of authorisations per person. So if a service provider doesn't already have a means of tracking the decisions and the submissions that have already been authorised, this will provide a means for them to do that. If they already have one, then either they can continue to use it if they choose to, and this will be a source of truth really in relation to what the decisions actually which decisions were made and when, but essentially this will become a centralised location of that information and data for them. And it will accumulate history from July 1. So one of the elements when it comes to authorisation decisions is to give some consideration to what has been the history in relation to authorisation for that particular purpose. What we're not asking is for back entry in relation to what the authorisation history has already been, because we need to draw a clean line in the sand in relation to what's acceptable and what's not necessarily what's acceptable, but certainly what information do we want to collect. Given that we're shifting our collection of definitions to align with the Commonwealth, if we had previous decisions associated with previous definitions within the same data set, it would create quite a messy landscape. So we're drawing a line in the sand. There'll be a growing history in relation to the particular person and what their restrictive practice history has been. The system will ask for the participant ID number, which is how we'll be able to track the RPAs associated with that particular person. It will also request the plan number. So one of the screenshots that Tracy showed you earlier had a plan ID number in one of the corners. I think it was 4-Gesundheit, but it was quite a lengthy one. So plan ID, participant ID will both be included in the submission information in order to help us track which practices go with which person, as well as which plan they're associated with. So after a period of time, your behaviour support plan may evolve a little bit for a short period of time, or a new plan may need to be developed which has a different number associated with it. What we won't be expecting is that those numbers are updated in between authorisations. We're not looking for that level of detail. We just want to know which submission the practice, which plan the submission per practice is associated with. So some additional benefits that the system will have. I think I've mentioned before that it's a secure platform to record, submit, authorise and monitor practice authorisation. The digitisation of the information for ease of distribution amongst panel members. Notification of upcoming authorisations, workflow approvals and rejections, and generates reports to analyse restrictive practices, submissions and outcomes by service provider, outlets or service settings. So outlets and service settings aren't different, just different terms to say the same thing. So, as of next week, a basic version of the online system will be available for providers and practitioners to access. The version will allow service users to register as a service user of the system, submit an application, record outcome summaries, and the fourth one there does say request a FACS independent specialist for the panel meeting. That won't be operational by next week, and if one is needed early in July, then certainly it would be via email until the system will actually have that function built into it. So we're expecting, as I mentioned, basic functionality by next week, and then increased functionality over the coming weeks. There will be a version 1.2, I think, by August, and version 2.0 by October. So we're certainly looking at having it as functional, as operational as we can, as quickly as we can, but the minimum requirements will be in place by next week. In addition to support on how to use the online platform for the lodgement of applications, there will be quick reference guides available. There will also be hover points throughout the system that where there's a question point, a prompt will automatically pop up. Training can be provided, but it's likely to be, the face-to-face training is likely to be on specific request for the time being. At the moment, we're a fairly small team with some capacity to expand, but limited resources at this point in time. Okay, so the policy document that I mentioned earlier will be available imminently, very imminently. I know it was sent through for uploading late last week, so it will be on our website any moment now, rather than any day now. The operational guide in relation to the restricted practice authorisation, how to implement it, essentially, will be available very soon. It won't be uploaded quite as quickly, but we're in the stages of finalising that document as we speak. Fact sheets will also be available, just to provide some information about what some of the changes are and what some of the requirements that sit in the Commonwealth versus the state space are. The next steps in relation to registration, service providers will essentially be requesting a registration form. They'll complete the request for an account, which is their registration with us. We will do that manually for a period of time, so essentially they'll lodge some information, provide it to us. There will be some uploading of information that we already have in relation to providers, but we will also need to check that provider against the registration with the Commission to make sure that they are an implementing provider associated with the delivery of practices that could be considered restrictive. Similarly, we will be checking that for practitioners as well. What does it mean? Okay. So service providers will be creating access for clinicians that will be part of their panel. So if any of you are members of restrictive practice authorisation panels, the provider who operates that panel will create an account for you within the context of their service delivery. We ask that when they do that, that you go and check and make sure that the information they've entered for you is as it should be. So, I mentioned that we're a small team at the moment. If there are any questions in relation to what are the authorisation requirements for New South Wales, what does it look like in practice, where do you fit with it, how do you navigate it, and where does it connect with the Commonwealth system, there will be a team for you to make contact with, and that's the Central Restrictive Practices team, and we will be located within FACS for the next couple of years. And it is led by 2 managers, a manager policy implementation and a manager clinical specialists. That team will support the implementation of the RPA policy and the RPA procedural guide. It will embed best practice advice and guidance in relation to the use of minimisation of restrictive practices into the authorisation process, and will provide assistance and oversight in relation to the online system to register and manage the requests for RPA, as well as providing independent specialists to participate in those RPA panels, and we absorb the cost of the provision of those specialists. So where it says provides and funds, we don't provide the funds for you to access somebody, we actually provide the somebody. And we will continue to coordinate with the NDIS Quality and Safeguards Commission. It needs to be pretty much a hand-in-glove type of relationship to make sure that what we're advising and requiring is quite consistent and complementary to the Commission's requirements. So what does that mean for all of you in relation to being behaviour support practitioners? Services are likely to draw on you in relation to your knowledge and understanding of restrictive practices and how they fit within the behaviour support context. So it's going to be important for you to review the restrictive practice authorisation policy and to become familiar with what the new definitions are and how our previous definitions align with the new definitions. So the table that I had up on the screen before in relation to how our practices will map into the new set is available within the policy, and as I mentioned, that's being uploaded almost any moment, if not already. So that information is available. You will need to be clear on what's needed for interim and full authorisation and who can provide that. You will also need to be clear on who is required to obtain that authorisation, and some of your questions earlier pertained to that in terms of where one service provider does implement and another doesn't implement, then what does that mean for authorisation? The application of authorisation requirements and implementation of those practices, you'll need to be reasonably familiar with those in order to continue to advise and provide support to the services you work with. You'll also need to familiarise yourself with the Commonwealth system and the intersection with the state requirements. So this presentation highlighted a couple of those in relation to you've developed a behaviour support plan, you've included a restrictive practice, you've flagged that that practice is going to be implemented in a particular provider, but that provider needs to obtain authorisation. You need to provide them with a copy of what that plan is. The draft plan won't be beyond draft until authorisation has been obtained. And also, what does that then mean for what you can upload back into the system in relation to evidence for authorisation? So it's how to export a draft behaviour support plan for upload to the RPA system, how to upload an outcome summary back to the state system, and how do you identify a service as responsible for reporting on the use of a restrictive practice. So that's going to be a fairly pivotal point for you as practitioners in identifying the providers that are responsible for that reporting. As soon as that provider accepts their responsibility in relation to that plan, they've accepted responsibility for reporting, and the Commission will be connecting with them to make sure that that happens appropriately. So the providers you work with, So the providers you work with, they will need to register with the online system and confirm any pre-populated information. So we will pre-populate the system as much as we can. They will need to familiarise themselves with the RPA policy and procedural guide as well. They will also need to become very familiar with the authorisation transitional arrangements, which align with the Commonwealth ones in relation to prioritisation. So some of the points that Paul mentioned before in relation to who the Commission might be most worried about in the context of someone with a behaviour support plan and authorisation, a little bit less worried about them at this particular point in time. So the same time frames apply in relation to the authorisation for that practice engaging with the system. And similarly, more concern for those individuals that do have a practice but may not have either authorisation or a behaviour support plan to support that, will be expected to engage with the system sooner. Service providers will need to do their mapping against the new authorisation framework, including the change of definitions. What we're expecting or hoping services will do in doing that mapping exercise is to get a sense of which practices are going to require authorisation sooner rather than later, so that they can then plan their engagement with the state-based system according to that schedule. It will also help them to map what their behaviour support requirements are if they've got practices in place that fit our new definitions but didn't fit old, and what does that then mean for plan development and the engagement of behaviour support. So the development of that plan, both for the purpose of engaging with the state system, will work well for the service in engaging with the Commonwealth system as well, given our expectations align. It's just making sure that the pieces of work are connecting with the appropriate system at the appropriate point in time. What I do emphasise is that if you're unclear on what any of this means for your practice and the support that you provide to providers, then ask. And you'd be asking us via that particular website or email address. If you are familiar with the Behaviour Support Unit at FACS email address, we will be forwarding those emails to this one quite soon. So you can still use either, but this will become the preferred one rather quickly. Additional resources will be available, such as the policy and the procedural guide with a summary, as well as how to access the RPA panel fact sheet, an overview of the panels and its expectations. The questions that you ask will be added to some of the questions that were asked at the previous workshop, and work towards informing some frequently asked questions resources, and information about what the central restrictive practice team functions will be, and roles and responsibilities in relation to RPA. So that concludes the presentation. So, questions. Similar format to the presentation earlier, roving microphones. Oh, okay. So how long for questions? 10 minutes? Okay.
Otherwise people could send questions today.
Yep. So if you have a question that we don't get to within the next 10 minutes, by all means either hold us up during the break or forward it through to this email address. But certainly, question?
Yeah, I'm just wondering, there are fact sheets available for family members, GPs, psychiatrists, people in the community basically, who are not necessarily part of the disability provider community, who would need to access information and be educated about this from the Commission's perspective. I guess I feel as though we can provide such information, but then I guess there needs to be a single source of truth for those people in the community to find out for themselves as well.
At this point in time, we haven't given too much consideration to the broader general information sheets. We can certainly take that on board. The reason at this point in time that we haven't gone there just yet is that we're focusing on resources specific to the providers that are going to need to engage with the system to make sure that they're reasonably informed as soon as we can. But we'll certainly think about what resources might be appropriate in that particular space. When it comes to the use of practices, it will still be in the context that was described before, in that it's about service providers that are funded to operate under the NDIS that are funded by NDIA. Yep.
Because I would imagine those family members and GPs and psychiatrists who are prescribing such medication would need to be appropriately informed about their involvement from the Commission's perspective. Yeah. Thank you.
Sorry, I'm just trying to clarify with the panel membership. In small organisations, normally you can pull a couple of people to be in that, and sometimes a lot of the behaviour support practitioners are within that panel. But from what I saw, they're not able to make a submission. So does that mean that the behaviour support clinicians can't be on the panel?
If the behaviour support clinician has a submission before the panel, they cannot be party to the decision to authorise that submission.
But they can still be in the panel?
And participate in decisions associated...
Outside what they want to submit?
Outside of their own work.
Okay, no, that's okay.
Provided there's still someone on the panel that can provide that independent perspective.
Yeah, no, that's all, because like I said, like say for small organisations, you know, the psychologist or whoever else is involved might be in that panel, but if that person is the one putting forward the submission, then obviously that person can be in there. So just getting my head around that.
Yep.
Thank you.
Sorry, can I just follow up on that? So as a small, as a small provider, so what would, I'm just a little confused about and I'm not coming from a not-for-profit background, so I'm new to this. So in terms of the relationship between the panel and myself as a service provider, do I need to put together, access an independent person as well as a manager from my own organisation? Is that what that would look like? I'm just a bit confused about how that would go. Or is there a separate panel that I would be able to access to submit my plans to?
The permutations are, I guess, a little bit wider for smaller organisations, in that for a large organisation they would have reasonable access to resources to operate their own panel, but there's an acknowledgement that small providers that's going to be tougher to do. So we have agreed that service providers can come together and form a bit of a conglomerate or a consortium model of panel operation. So as a small provider, you can form an arrangement with a number of other providers and have the appropriate expertise part of that panel. What's important though is that a manager from the service where that practice is going to be implemented has to be party to the decision to finally endorse its implementation, because there's an operational commitment or an operational endorsement to make sure that as a service they're aware that that practice is going to be used in their service. They've made sure that their staff understand when to use it, when not to use it, how to use it, and that they've done right by the person by making sure the appropriate behaviour support is in place, and it's the least restrictive option. So how you go about making sure that that is covered in the panel is a little bit open in terms of how services come together to fulfil that requirement.
Okay. And does the person with behaviour support expertise need to be a registered provider?
That's a good question. So within the context of our FACS register, our register of FACS specialists, we are requiring that they are eligible to be a provider, but not specifically registered. So where you are drawing on behaviour support expertise within your own service, that's a little bit tougher. So we might need to work through the specifics of that particular situation.
Okay, and this sort of goes back to, because the people that I would look to access would be board-certified behaviour analysts who, as of right now, aren't falling under registration, so that's where it gets a bit tricky. Okay, thank you.
Okay, so 3 really quick questions. Is there a cost to use the online FACS panel? No? Great. What time frame, so for restrictive practice is expiring in a month, is that enough time for the panel, for the FACS panel to approve, or what time frame do you need approximately?
So it would be the panel associated with the provider that's implementing the practice. So it's not actually a FACS panel. FACS will provide an independent specialist to attend the panel of the provider. So where your behaviour support plan is going to be implemented with a provider, they're responsible for getting a panel together. And if they don't have access to behaviour support expertise, we can provide expertise to that panel.
Okay.
So in relation to the time frame for that, that provider, I would suggest they make contact with us perhaps, and we can talk about what's possible within the time frame. But so where did the 1 month come in? I wanted
No, I was just wondering. I thought the online submissions were actually FACS providing the approval.
No, FACS isn't providing the approval.
So it's just an online system to monitor it.
That's right. So it's an online system for all panels within providers to access to process their own authorisations. So we're going to have dozens, if not hundreds of service providers accessing the one portal and managing information within the confines of what's visible for that provider. Yep.
Is there a time frame whereby we have to have registered by? Or?
The slide that had the ticks and crosses outlined some information in relation to, depending on the features of the situation. So if a practice already exists and if it's already contained within a behaviour support plan and already has authorisation, then that would be 12 months. If the practice already exists but isn't contained within a behaviour support plan, then there's a period of time in terms of getting an interim behaviour support plan and interim authorisation associated with that. And I think that was 3 months. Yep. Yes, but we do want service providers to connect with that portal as soon as they can in order to make sure that we've got the registered providers within the platform. One more question.
I've just got a question about the responsibility of the practitioner when you get outcome summary feedback. So it may be the case that we've written a plan for someone a number of months ago and the referral's been closed, and then received some feedback around some amendments to the plan.
Yep.
Whose responsibility is that? From my perspective, I would potentially feel compelled to make those changes, but that person might not have funding or might not have capacity.
Yeah. If it's the first point at which authorisation is given for that particular behaviour support plan, behaviour support clinicians would still be involved for that period of time, because the plan won't be completely active in the Commonwealth system until authorisation has been obtained. If it's after that period, after the initial authorisation though, and it's either a review or a reauthorisation, then it would be the provider's responsibility to make sure that there's a behaviour support clinician to act on the recommendations that came from the panel, I believe. Just checking. Yep, everyone's nodding. Okay. All right. Any further questions, then grab us during the break, or please email that email account. Thank you for your attention.